Okay.
Gaps in supporting breastfeeding in Kenya. Today's presenter is Virginia Wanjiku. And before I welcome Virginia to take us through this today's presentation, I want us to just highlight something very brief about World Breastfeeding. And we are saying World Breastfeeding Week is an annual event celebrated from August 1st to 7th to promote and support breastfeeding worldwide. And organized by the World Alliance for Breastfeeding Action in collaboration with the World Health Organization, that's WHO, and also UNICEF. It aims to raise awareness about the benefits of breastfeeding for both infants and mothers, and also the family members at large. The week emphasizes the importance of breastfeeding as a key element in ensuring the health and well-being of children and highlights the needs to support all at all levels. So thank you so much. I'm Robert Kemboy, your moderator. Welcome, Virginia.
Good morning, everyone. My name is Virginia, as Mr. Kemboy has said. I'm going to take us through the World Breastfeeding Week celebration. We've had the celebrations from 1st to 7th of August, and it has been a fruitful week for the nutrition fraternity. We are doing the closing ceremony for KNH, and I think it marks also for the country. There are a few other events that are planned all the way to next Monday for World Breastfeeding Week. There's a launch, there's a webinar that is going to be on Monday, where we'll have our legislators giving some feedback, giving some talk. But today we are doing the finalization of the KNH celebrations. So welcome. So the World Health Organization, that is WHO, recommends starting breastfeeding within the first hour after birth, exclusive breastfeeding for the first 6 months, and then continuing breastfeeding along with safe and appropriate complementary foods up to 2 years and beyond.
Recording in progress.
Okay, sorry for that. So exclusive breastfeeding for the first 6 months helps to reduce infant sickness and deaths from infections like diarrhea and pneumonia. So breastfeeding is crucial for infant health and development, providing essential nutrients and strengthening the mother-child bond. In Kenya, despite the known benefits, there are still significant gaps in breastfeeding practices and promotion. And that is what brought us to this year's message, where we are talking about okay. So the presentation outline, the first bullet is we are going to look at the overview of World Breastfeeding Week. We're also going to look at the World Breastfeeding Week 2024 theme. We're also going to look at the nutrition and breastfeeding status in Kenya and the policy and legislation protecting the breastfeeding rights of our children and our mothers in Kenya. So to start us off, we look at where we started. World Breastfeeding Week is a global campaign to raise awareness and galvanize action on themes related to breastfeeding. That means it awakens us to be able to know that breastfeeding is key and crucial for our babies. And it tells us about the importance and what do we do as stakeholders in terms of building a healthy nation.
Recording in progress.
So we'll start with the evolution of the World Breastfeeding Campaign. So World Breastfeeding Week is celebrated every 1st to 7th August of every year in commemoration of the 1919 Innocenti Declaration. So it started in 1993. with annual themes including healthcare systems, women and work, the International Code of Marketing of Breast Milk Substitutes, community support, ecology, economy, science, education, and human rights. So all those are part and parcel of what themes we look at when we are dealing with matters of health for the mother and the child, because each of those components will affect the health of the mother and also will affect the health of the child. So since 2016, WBW is aligned with the Sustainable Development Goals, what we call the SDGs, in trying to ensure that we are in line with them and we assist, or we are able to help in ensuring that they are achieved. So in 2018, a World Health Assembly resolution endorsed the WBW as an important breastfeeding promotion strategy. Remember, for breastfeeding, we need to be able to promote, support, and protect breastfeeding. So this one was picked up as one of the easiest way to be able to promote breastfeeding. Kenya, being a member of the World Health Assembly, also adapted the strategy. So since then, Kenya has been celebrating the week, and every year we have a different theme. So for this year, we need to be able to bridge the gaps that are there for breastfeeding. So the WHO recommendations for early feeding and breastfeeding. So what are these recommendations? We have 4 recommendations for breastfeeding as per the WHO. The first one is immediate initiation of breastfeeding within the first hour of birth. So all mothers are supposed to initiate their babies to breastfeeding within the first 1 hour of birth. Number 2 is exclusive breastfeeding for the first 6 months of life. And that is very key. We also have number 3, sustained breastfeeding for 2 years or beyond, alongside appropriate, adequate, and safe complementary feeding from 6 months. The 4th one is optimal maternal nutrition and social and community support. That means the mother needs to be healthy and also needs to be supported once they leave the hospital, if they have, because they deliver in the hospital and they come for antenatal care in the hospitals. What happens when they go back to the community? They need to have social and community support, and that is where we have a strategy called the Baby Friendly Community Initiative, where we support mothers at the community. When they come to the hospital, where we have the first 3 strategies, we are able to offer what we call the Baby Friendly Hospital Initiative to be able to help the mothers within the hospital ensure their babies are healthy and themselves they are also healthy. So when it comes to the hospitals, or when we come to the community, how do we establish and sustain breastfeeding for 6 months? So for the hospitals that are practicing baby-friendly hospital initiative, what they need to ensure is that there is immediate and uninterrupted skin-to-skin contact from birth and initiation of breastfeeding within the first hour of birth. It is very easy to skip this part because most mothers, there are many procedures that happen within birth. So it is important to remember that that needs to happen, and the mother needs to know that this needs to happen. So we create awareness immediately at antenatal so that they know, the mothers know when they are at the delivery table, they are able to be given their baby for skin contact and be able to be in contact with their baby within that first hour of life, given that there are very many benefits of having that skin-to-skin contact. Number 2 is exclusive breastfeeding, where we ensure that our mothers are not giving their infants anything else, including water or any other fluids. We also have what we call prelactio feeds. There are communities that give their babies some herbs or some oil or some fat when the baby is born. Those ones we discourage and try to handle the myths that the misconception that a child needs to take something once they are born before they start breastfeeding. So we ensure that our children or our babies are not given anything when they are born. Number 3 of how we sustain breastfeeding is breastfeeding responsibly. That is, you breastfeed as early and often and as long as the baby wants, day and night. This is what we call breastfeeding on demand. the baby has to breastfeed. We don't wait for certain times. We don't wait for when the baby is asleep, we don't wake the baby up. It means that any time is breastfeeding time. That means we breastfeed as often as is required, both for the mother and the baby. Number 4 is we counsel our mothers on the risk of feeding bottles, teats, or pacifiers, and cups with spout. It is increasing now that our mothers are using a lot of bottles, and we'll see the data. They are using bottles with teats, and the pacifiers are on the increase. Every other mother who is looking like they have what tunaita kuomoka, they use pacifiers, and it's very hard for that child to be able to breastfeed if they are already introduced on pacifiers. The cups with spout are everywhere, and we need to be able to counsel our mothers as much as these items are in the market. These are prohibited products, and we need to ensure that they are not using them. The information that we give them will help them not buy them or use them, even if they're available in the market. So this leads us to the theme for this year, where we have closing the gap, breastfeeding support for all. And the gaps that are there are the ones we need to be able to stop. So how do we stop this gap? We'll first look at the data that we have to be able to see what has been happening. So we look at nutrition and breastfeeding status of children in Kenya, and the data talks. And when the data talks, it means that it calls us for action. And let's have a look at it. This is the initiation of breastfeeding within 1 hour. And what does it say? Many infants in Kenya do not start breastfeeding within the first 1 hour of birth. The delay in initiating breastfeeding affects the baby's health and nutrition. Currently, only about 60% of infants are initiated breastfeeding within an hour of delivery. Of those women who are delivered by skilled health professionals, 1/3 of them are not supported to initiate breastfeeding timely. Furthermore, there are disparities that exist within regions, with Vihiga County having the highest rate of early initiation to breastfeeding at 87.2%, and Kisumu County with the lowest at 21.5%. When looking at the graph that we have in front of us, mothers who had a vaginal delivery are at what percent? At 65%. The mothers who had a cesarean section are the ones who are usually affected by this early initiation because of the procedure, the cesarean section procedure. So that one goes at 34%. This is as per the KDHS 2022 that was just done recently. And so this is current data. We have mothers of infants in rural areas. They're at 63%. And mothers of infants in urban areas at 55%. That means that we need to be able to work, because we are supposed to be at 100. And we can see our data going all the way to 34%. So what do we do for these mothers who are not able to initiate breastfeeding within the first 1 hour of birth? So what are those measures that we need to put? That's a question we have. Looking at data again, the trends of exclusive breastfeeding through the years. The first KDHS, 1989, we were 23%. In 1993, we moved to 17. In 1998, we went to 13%. 2003, we remained at 13%. In 2008, 2009, a lot of effort was put in ensuring that our exclusive breastfeeding rates have gone up. And what happened? The rates went high to 32%. Then in 2014, all the measures that were put in and intervention put in across the country, we had the laws being shared, the laws, the BFHI what is it called? BFHI being utilized in hospitals. We went all the way to 61. That is where we also started the baby-friendly community initiative, and that improved our data to 61%. So a lot of activities went there. Something happened between 2014 and 2022. our data went down from 61 to 60%, and that's a drop. We need to be able to see what is giving these rates. Why are the rates going down? And we'll see what is causing that. 60% of infants, as I've said, are exclusive breastfed. And as the babies get older, exclusive breastfeeding decreases. We only about 38% of our infants, 4 to 6 months old, being exclusively breastfed. 65% of infants, 12 to 23 months of age, continue to breastfeed. That means we have gaps. 35% of our children are fed by bottles. 35% of our children are fed by bottles. And that is the figures we have here. And here we are comparing data between 2014 and 2022, whereby in 2014, our data for early initiation of breastfeeding within 1 hour was 62. And in 2022, we were at 60%. Exclusive breastfeeding below 6 months, 2014 was at 61%. We have gone down to 60%. Exclusive breastfeeding below 1 month, this is new data that was collected, and it showed we were at 77%. Exclusive breastfeeding 4 to 5 months, this is where most of our children are challenged. It shows in 2014, we were at 42%. We have gone down to 38%. That means we need to do something. Continued breastfeeding at 12 to 23 months. Initially, 2014, we were at 75. We have dropped by 10%. We are at 65%. The children who have ever been breastfed, at least that data shows we have 99% in 2014 and currently at 98%. It means that the children who are not breastfed because of the various reasons are not many. And so we are able to breastfeed all these children at 98%. If all the children who are ever breastfed are 98%, why do we have our rates going to 60 for exclusive breastfeeding for 6 months? Then we have bottle feeding, 0 to 23 months. You can see it went up. From 22%, it went to 34%. It means that more of our mothers are using bottles to feed their babies. When they go to work, when they go to the market, when they go for social activities, they are leaving their babies with bottles to be fed instead of using pups to feed their babies on the milk that was expressed. So that's something we need to be able to tackle as a country. So we're looking at the trends in nutrition status of our children. Looking that our data is going down in terms of breastfeeding, where are we at in terms of nutrition status for our children as they grow? 1993, we started with let's start with stunting. We started with 40%, 98 we were at 38%, 2003 we went to 36. We have reduced all the way to 2022 where we were at 18%. That means we are reducing the rates of malnutrition for our children. That is for stunting. For wasted, the children who are wasted, we came from 7, we went up slightly by 1 score from 4% in 2014, we are standing at 5%. For the overweight, these are numbers that we are also reducing because remember we have children who are overweight depending on how they are fed and different factors, and we have the rate going down to 3%. This is a rate we need to be able to tackle also as we are looking at malnutrition. Because remember, children who are bottle fed, children who are given infant formula at the beginning are children who are bound to be overweight. So we need to look at that trend and see where is it going and are we able to reduce it. So what are the effects of malnutrition on child deaths? Looking at the chart we have ahead, malnutrition contributes to about 45% of all under 5 child deaths. That means 5 in every 10 children died due to malnutrition. There are many other causes of death for children. We have pneumonia, we have those are the upper respiratory tract infection, of which pneumonia is one of them. We have ear infections and any of the other infections. The one that is the highest contributor of death is malnutrition. So we need to be able to tackle that. Poor breastfeeding and complementary feeding practices contribute to 19% of this death. So we need to be able to handle the 19% by ensuring that our children are breastfed right from birth. We have a category of our mothers who are adolescents. We have them teenagers and adolescents, and that's a cohort that we have to look at keenly. These are young mothers who may not have knowledge or support for breastfeeding. They also face stigma among their peers and may be away from their young children when they return from school. So this is a cohort we cannot forget or we cannot assume, because remember, they're supposed to be in school. All their peers are in school, while these ones have delivered. Sometimes their children are taken away, so they are told you have to go back to school immediately. And that means that mother will not be able to breastfeed. When she goes to school, she has nowhere to express her milk. That means that even if she wants to express, the children in school or the other peers will almost be likely laughing at this person. And they want to see what is happening. So that's a cohort we need to really work on and make sure that, or ensure that they are breastfeeding their children, the laws support them to be able to tackle themselves. So looking at the data that we have, and I'm sure we have seen where we stand as counties on the data that we have, everyone should have access to breastfeeding support and opportunities. And to achieve this, we need to work together with all stakeholders to close the gaps in breastfeeding that we have seen and reduce the inequalities that are therein. So that means we need to promote, protect, and support breastfeeding and close the gaps that we have seen. So how do we ensure that we do that? That means the first thing we need to do is focus on survival, health, and well-being of our mothers and our baby. Breastfeeding can act as an equalizer. It means that we improve our breastfeeding support to reduce inequalities of each and every category of our mothers and children. And looking at them, we have those ones that have special requirements, and we need to take care of them. Those are the women, as we have seen, most likely living in rural areas where they have inadequate coverage of MIYCN interventions, activities for mothers there. They may lack information. We need to ensure that we bridge that inequality by giving them support. And we appreciate the government for bringing the community strategy where we have anchored our breastfeeding support in the community, where our mothers are visited by including the CHPs under the new strategies. We have empowered them as a country to be able to support our mother right from their house, and they get this information. We have the urban poor, where most mothers in urban areas work in the informal sectors without maternity leave or breastfeeding facility, and the coverage of MIYCN interventions remain low. Because remember, in urban areas, it's sometimes very hard for them. Everybody is up and about. And sometimes they don't have the support that is there as a community in the villages, in the rural areas. So this is a cohort that requires us to be able to look at in terms of breastfeeding. And I've talked about the adolescent mothers. We have those mothers who live with HIV, who often face stigma and may receive conflicting information about breastfeeding. And even though the Kenya guidelines support breastfeeding with antiretroviral therapy, it's very easy for those mothers to get information that may not be of good help to them. So we need to ensure that they are also taken care of. We have working mothers, and those working mothers need a lot of support. And the support requires that once they go to work, what is it that they do once they go to work? Before the baby is 6 months, what are these strategies that they need to put in place to ensure that they are continuing with breastfeeding and that breastfeeding will not stop? And they will not say, I don't have enough milk, which is one of the difficulties that mothers face a lot. So challenges include the maternity leave. How many days do they get for maternity leave? Also, the absence of breastfeeding facilities at workplaces. That is a challenge that they have. We also have limited employer awareness about the benefits of breastfeeding, which is crucial. And that means we need to ensure that our employers are aware of the benefits of breastfeeding, and they need to put facilities at the workplace to be able to support these mothers. We also have those mothers in prison. We receive them in the health facility, like where we are in KNH, we have them, but we have those mothers who are within the prison. That environment, is it conducive for breastfeeding? We can be able to support them in one way or another to ensure that we talked with the prison management to be able to ensure that. And for that, this year's World Breastfeeding launch went to the Langata Women's Prison, and that created awareness within the prison management and the law enforcement to be able to let them know that they need to be able to support those mothers even if they're in prison. We have also mothers and caregivers in emergency and crisis. Kenya has faced a lot of emergencies in the near future. We had mudslides, we have the rains, the floods, we have had a few wars running in some counties, and those are challenges that have separated mothers and children. And some of them have had mental issues because of those emergencies. There are also myths and misconceptions around infant feeding during emergencies, and they need to be tackled. When we have emergencies and crises, breast milk substitute violations are many in that everybody wants to donate some infant formula somewhere. So how do we manage that? We need to be able to follow up and see, are we assisting our mothers in emergencies? Not to use the breast milk substitutes when the mother's milk is available. We also have reduced dietary intake because remember, in an emergency, we take what? We take a package. They do not have the food they usually get at home. So we give them a package, and that package, is it adequate for the mothers who are breastfeeding in the camps that we have or in the areas that they have been displaced to? We also have gender violence that is meted on the mothers. A mother is pregnant, she's thrown out of her house. What happens with her? A mother is breastfeeding, she's thrown out of her house, or she's beaten. She cannot even have time to breastfeed her child. Sometimes she has to go to hospital and be there for a few days getting treated. How does she get assisted to ensure that she continues to breastfeed her child? Yes. So those are mothers in emergencies and crises. We need to help them. When we look at the healthcare system, there is low coverage of baby-friendly hospital initiative, coupled with inadequate human resource. And that means sometimes when you go to a health facilities, the number of staff to patient ratio is sometimes low, starting with the nutrition numbers. Then we go to the other cadres, and we need to ensure that we put up a good number of staff to be able to cater for all the mothers that come to our health facilities and be able to make most of our facilities baby-friendly hospitals. We have inadequate targeting of the private sector where most of the violations occur, and we need to be able to talk to them, be able to engage them. And I think most of the time it's the information that they don't have, and we need to ensure that we give them enough information, involve them within the counties to be able to know that this is what needs to be done. Instead of just focusing on the government sector, we need to look at the private sector. We also have the training institutions where our curriculums need to be updated for both in-service and pre-service. Because why? You will find that the students who come around for practicals, sometimes they have information that is way back that has not been updated. So that means that we need to be able to update the information with the current data that is available. So that will ensure that everyone has access to breastfeeding support and opportunities. We are leaving no one behind. Vulnerable mothers, anybody who needs additional support, gets their support. Special focus, as I've said, on those who are breastfeeding in emergency and crisis. And we are working with actors along the warm chain to close the gaps in breastfeeding and reduce inequality. The warm chain means that everybody handling a mother and a child, right from the household. Who sees this mother? Is it the community health, the community health promoter? What information are they giving? Are they giving the right information? all the way from level 2, the health centers, coming all the way up to the level 6 of healthcare, and also at the policy level, what happens there. So everybody working with the mothers needs to be able to have information and be able to assist our mother, or they should be able to promote, support, and protect breastfeeding. So the objectives for this year, World Breastfeeding Week, the first one was to inform. What does it mean? It means that we inform people about inequalities that exist in breastfeeding support and prevalence. Those are the ones I've just shared for all the mothers who need care and for all the mothers who need to be taken care of. And also everybody who is in support of this needs to have this information so that we're able to bridge the gaps. That means information need to go. Information need to be passed in any way possible. Let it pass. And I think in the past few days, we have been able to pass a lot of information about breastfeeding and how to support the mother. The next objective, number 2, we need to anchor breastfeeding as an equalizer to close gaps within the society. Everywhere the mother is, everywhere a pregnant mother is, everywhere there's a breastfeeding mother. If she wants to breastfeed in a matatu, let her be able to breastfeed. Is there a workplace support, even at the marketplace where we have the informal sector? We need to anchor breastfeeding. Is the mother going to church? Is the mother going to a prayer place? Is there somewhere this mother is supported to be able to breastfeed? We anchor it in every part of our society so that we can be able to close the gap. Objective number 3 is where we engage with individuals and organizations to enhance collaboration and support for breastfeeding. Wherever we are we having collaborations? Are we talking to the people who can be able to support us? Are individuals aware? Do we have that community support? Do we have the organizations that are possible? Are we talking to them to be able to ensure that there is that collaboration and support for breastfeeding, both from the private side, from the government side, and from the community side, so that we can be able to achieve our objectives. The last one, number 4, is where we galvanize. To galvanize is to call to action, put a fire. We are supposed to raise a fire, put into action on reducing inequalities in breastfeeding support by focusing on the vulnerable groups, the ones that we have mentioned. And we need to be able to light a fire for this year, these gaps that are there, that we keep seeing. That mother who is not able to breastfeed, what do we do? That mother who is pregnant, what do we do? We need to cause a fire, call everyone, including the parliamentarians, including the management of where people are. That talk needs to go. A fire needs to be lighted right now so that we can be able to act. So those are the objectives for this year, and we need to be able to meet them. So looking at them, what are these gaps that we are trying to close? That is breastfeeding. We have seen that lack of breastfeeding support during the critical first week. That is early initiation of breastfeeding and skin to contact within 1 hour negatively affects the overall breastfeeding intentions and prevalence. And we are able to look at data because data does not lie. It is what is. So that affects our breastfeeding rates and our intention of ensuring that all children get to be breastfed. Remember, all mothers are able to breastfeed given the right support to be able to undertake that activity. We also have these unregulated donations of breast milk substitute, which combined with a lack of access to clean and safe water during emergencies, place infants and young children at a higher risk of malnutrition and mortality. And not only during emergency, even regularly within our areas, we have seen a lot of breast milk substitute being marketed everywhere. We have the law that protects that, the marketing and distribution of breast milk substitute, but it has gone unregulated, and we can see shops, markets, even small shops within our communities are selling the breast milk substitute. That is the infant formula. We need to see how it affects our children. And we have seen the data. If we give our children the breast milk substitute, we deny them the right start, unless it is medically indicated, where we cannot avoid to use a breast milk substitute. At that point, we will be able to use that substitute under those conditions. And there are few conditions, and that means we can only give a breast milk substitute if there's a prescription for that. And most of that happens within the hospitals. And after the mother leaves hospital, we need to know, is she continuing with the breast milk substitute or not? But it needs to be under a lot of guidance for us to be able to give a breast milk substitute so that we give the baby the best start in life. Breastfeeding can act as an equalizer in our society, and efforts must be made to ensure everyone, especially the vulnerable group, have access to breastfeeding support and opportunities every month, whether they are in the village, that is the rural areas, whether they're in the urban areas, whether they are unwell and they have gone to hospital for one reason or another. It means that everywhere a mother is, she can be able to get access. And as an equalizer, it means that all children are able to achieve their full potential in life by getting the first start or the best start in life, and that is breastfeeding. Protecting, promoting, and supporting breastfeeding addresses inequalities that stand in the way of sustainable development. Kenya also has made headways in ensuring that the sustainable development goals are achieved, and breastfeeding is able to help us achieve these sustainable development goals. And there are 17. It is their reduction of poverty. If a child is able to achieve their full potential, they'll be able to be active in life later, and there will be no poverty. Zero hunger. How do we ensure that there's zero hunger? Breastfeeding support is one way of ensuring that we reduce hunger by ensuring that our mothers who are pregnant, mothers who are breastfeeding are able to get their full potential. They are able to get their meals as they are required. Remember their recommendations to eat the 10 food groups for the mother. Are they able to achieve that? How do we achieve that as a country? So looking at the 17 of them, breastfeeding is a key factor in them. Maternal nutrition and the breastfeeding factor. That means that investment in breastfeeding to address these inequalities is vital and can help alleviate the social inequalities. It means that we need to invest in breastfeeding. Kenya is targeting to move from 60% to 75% as at the next KDHS. In the next, we have gone a year, 2 years. That means in the next KDHS, we need to go to a level of 75%. We need to work hard so that we keep that gap. 15% is not a big percent to add, and we need to be able to address that and increase that percentage. And because that's the target as a country, to get to 75%. So what have we done as a country? Let's start at the policy framework. Looking at the Kenya Constitution that was enacted in 2010, we have Article 53, number 1C, which states that every child has a right to basic nutrition. So where does it start? At birth. And for that, basic nutrition, breastfeeding comes there. Remember, we have maternal nutrition. And so when we talk about basic nutrition for this child, it starts from the time of conception. We call it 1,000 days. And 1,000 days starts from conception all the way through the 9 months of pregnancy and the time the child grows, from the time they are born, where we start with early initiation, all the way to the time the child is 2 years. So every child has a right to basic nutrition. The Employment Act 2007, Section 29, talks about the maternity leaves. And this is a long walk. For those who are there before this time, in 2007, we know maternity leave used to be 2 months. And it was increased to allow for 3 months maternity leave, after which women return to work. And we have those workplaces that allow the mothers to take their maternity leave plus their leave, their yearly leave, in addition to the 3 months. That means that they have an additional 1 month there. That means by the time they are getting back to work, their child is about 4 months. And that is an addition to some workplaces and some human resource in those workplaces are able to support that. But the law states that we get 3 months maternity leave, after which they can return to work. Fathers are also given 2 weeks paternity leave to be able to support the mothers within that crucial 2 weeks of after delivery. So the law protects us in that manner. Also, we have the third act, the Breast Milk Substitute Regulation and Control Act 2012. And it was enacted in 2012, but came in force in terms of enforcement in October 2012, where now the mandate of ensuring that there is no appropriate marketing and distribution of breast milk substitutes. Also, there is safe and adequate nutrition for infants through the promotion of breastfeeding. And also, there is proper use of breast milk substitute where necessary and for connected purposes. Remember, we only use breast milk substitute when they are medically indicated, and that means what we do is we don't ban the breast milk substitute. What we do is we regulate their marketing and distribution to ensure that it's not getting to the mothers unnecessarily when they are not required or they have not been prescribed. So the law in Kenya protects us to be able to breastfeed our babies and support our mothers. So there are various areas of focus in Kenya to close the gap in breastfeeding and stop inequalities and support breastfeeding for all, especially the vulnerable groups. So we have various actors in the country where we have the government and policy makers. We have several commissions. We have the nutrition, what we call the Division of Nutrition, that really works very hard to ensure that the policies that they make support breastfeeding, especially the MIYCN, the Maternal, Infant and Young Child Nutrition section. So the government is usually very supportive. When you talk to the managers, starting all the way from the CS, coming all the way down to the health workers, it's very easy to be able to support. And we have work to be able to close that gap. We also have civil society organizations that support, and those ones help in various activities within the communities, and they engage most of the time with the government to be able to close this gap, and we can bring them on board to be able to support. We have the healthcare system, including the pediatricians, the nurses, the midwives, the nutritionists. This cohort can be able to ensure that the mother and the child get a good start. So these are the actors in the health system that we need to work hand in hand. Let it not be an isolated act. Let there be some cohesion and teamwork between the teams to be able to give the best support to our mothers and to our babies. We also have the Disability Council. Remember, we have our mothers who may be living with disability, and through their council, they can also be able to be supported to also be able to offer adequate and optimal breastfeeding for their adults. We have the NDMA, which helps us gather information on how the trends are going in terms of hunger, in terms of many things. And so that gives us data. Most of the data could also be emergency data. And that is also, it tells us in terms of preparedness, how do we need to prepare for several activities, including the emergency. In addition to the NDMA, we have the emergency responders, where we have like Red Cross, who responds very fast, who have a mandate of ensuring that our mothers and children, when there's an emergency, we are able to assist. In the emergency response, we have the package of training, and we also have follow-up, ensuring that maternal, infant, and young child nutrition is emphasized during an emergency. So that's part of how we can be able to close the gaps during emergency. We have special programs. That's a department in government that is able to help us when there are special issues. How are they handled? And that is part of the actors in that. We have the media. The media is a very big actor in helping us to close the gap. Remember, we have radio, we have TV, we have the social media groups And these social media groups have an impact because once information is passed, it's able to be distributed to many other people. What they call the Gen Zs, they call it you pass the information. What do they call it? Forward, or you share it to the next person. You share it to the next person, and they can be able to see. So if the
Recording in
information,
progress.
sorry for that. So if the information is going in right through our media, our various media system, we can be able to bridge this gap, ensuring the right information passes. We have workplaces, both formal and informal sectors, which need to have the information of what is the importance of breastfeeding, the importance of supporting the mother so that we break these inequalities. We have the communities, we have our parents. Remember the community as large. You have your brothers and sisters, you have the community around you. Are they able to assist you to handle this baby? And can they come and probably be able to cook for this mother? Can they able to come and help this mother to hold a baby so that she can sleep for a few minutes? The parents, we have the parents that are parents for this child that has been born. And we also have our parents, we call them the grandmothers and the grandfathers. They have a big influence because remember, a grandmother breastfed this mother or this father for this child. And what they say, they'll always say, I did this to my son, I did this to my daughter. So it is possible we do the same for this child. And so we need to be able to help them support, give them the right information. And through the baby-friendly community initiative, we have what we call the community mother support groups. And these community mother support groups are able to engage the actors within the communities where these grandmothers probably are in them to be able to pass the right information and be able to support a mother who is pregnant and one who has delivered. And we also have the religious groups. The religious group help us to ensure when our mothers are in the churches or in the various religious gathering, the mosque and everywhere else they go to pray, how if they have carried their child, how are they supported? When do they come back to church or when do they come back to worship? There are various religions that we have in Kenya. Kenya is a religious country and we have freedom of worship. And that means these religious groups need to be able to help the mother. If there can be a breastfeeding corner within where they are worshiping, how are they able to create that? So those are actors that we need to be able to call to be able to help us close this gap. On the other side, we have the mothers themselves, who are the main actors, who are our main focus. We have the adolescent mothers and caregivers. We have the mothers and caregivers in emergencies and crises. We have the mothers and caregivers who have a lower education, who even if we put posters or we give them the book to read, we have the mother-child handbook. Are they able to read that? So we have those ones who have a lower education, who did not get education that we went along. So those ones are still also our focus. We have mothers and caregivers in rural areas. We have mothers and caregivers in the lower wealth quintile, those ones who may not be wealthy enough to be able to cater for 1, 2, 3. We still need to be able to ensure that they are healthy and their babies are healthy. We have mothers in institutions like the ones in prison. We have the mothers working as casual and skilled professions. Those ones are our focus. And we need to ensure that they are fully supported. In the community, we have the mother-to-mother support groups, which give them information, which are led by the community health promoters, and they assist us to be able to handle this mother in such a way that they get all education that they need. When they get to the hospital, they should also be able to be assisted as they are going through their hospital procedures at antenatal clinic, at the delivery point, at postnatal care. They need to be able to be supported, to be able to get the right information and also follow up after delivery. When are they seen the health facility after they have left? Because at the community, we can be able to support them and also be able to support them. Let's focus on them so that we bridge those gaps and inequalities. So the breastfeeding support what do we need to do for each of the objectives that we had for World Breastfeeding Week. When we come to inform, we are looking at KNH, and we're also looking countrywide. The first one was inform. What do we inform? We inform people about inequalities that exist in breastfeeding support and preference. So what do we do within the hospitals? We have like KNH, we have held health talks within the hospital. I believe that happened within all the other all the other hospitals within the countries. They were able to give health talks within their health facilities. I believe all of them were able to hold sensitization meetings for various stakeholders. We had engagement with the media. For KNH, we had engagement with the KNH management, the different department heads. And I believe that happened within the counties because I saw enough in the different forums where we had our nutritionists, our nurses talking about this breastfeeding within that week. And we were able to support. So those sensitizations meeting happened with all those different stakeholders. Informing means that we create awareness on breastfeeding to the public through a launch. We had a launch, the main launch from the Division of Nutrition, which happened at Langata Women Prison. And there were launches within the different facility. KNH also had a launch on 6th, and we were able to launch the breastfeeding week within us as we continued with other activities. There were several TV and radio messages. In KNH, we had telephone messages going to staff and also to other stakeholders or the patients that we have or the clients that we have within the facilities. There were messages running within our telephone exchange to be able to reach the bigger audience for us. We had messages going to every staff in KNH to ensure that they know we are holding the World Breastfeeding Week, and the messages are we close the gap, and they all know what they need to do as they are closing the gap. Then a webinar was supposed to be held. This is one for KNH. We have the one from the Division of Nutrition, which will take place on Monday. I believe we have the links. If the links are not available, they will still continue to be shared so that you can be able to listen in as a close to this information that you are still giving. The TV and radio sensitizations are still ongoing, radios are still calling. From vernacular radios, I think we have had them in all languages. So the information went. So we were able to meet that particular objective, and we are going to continue with it. To anchor breastfeeding as an equalizer to close the gaps within society means that we launched the national, we need to launch the National World Breastfeeding Week at county and national level, which took off, and all of us in the country were able to celebrate as a country. World Breastfeeding Week activities were able to be conducted. I saw most of them going on, whichever county it was, they were happening. The last one is intensify BFHI implementation. For the baby-friendly community initiative, activities have been ongoing for the support of the community. At the hospital is where now we are looking again at the baby-friendly initiative and doing the trainings, ensuring that the health workers are aware where there's a maternity, ensuring that the mothers, the staff are able to give the right quality, following the 10 steps of the hospital being baby-friendly. The engage, our third objective that we had, engage with individuals and organizations to enhance collaboration and support for breastfeeding. So at that, it means that roundtable discussions with partners, including Division of Nutrition, MOH, we had very many actors. UNICEF was on board, many actors. I saw very many actors during discussion, and it happened. Within the counties, there were different partners, and they were able to assist in ensuring that the activities are ongoing and the information is passed. There are also roundtable discussion with the emergency responders within the hospitals and also outside the hospital. So that the places where we had emergencies within the recent past, we had before, and we still had engagement with them in the recent, so that if an emergency happens, what do they do? that has happened in the various counties. There have been discussions with different stakeholders. It means that different counties have been able to talk with probably their directors, human resource, KNH, you are able to do that. In fact, our launch for World Breastfeeding Week for KNH has our human resource director as a guest of honor to be able to ensure that the staff of KNH and the clients that we have are able to get the appropriate care that they require. Number 4, on galvanizing the actions on reducing inequalities in breastfeeding support by focusing on vulnerable groups. We have the human resource and other heads of department to garner their support everywhere that our mothers are. In the hospital, we have different departments. Then it means that those ones need to be part and parcel of it. In KNH, that is the way we took it. In other setups, I know there are other ways of handling it, but it means that ensuring that even if it's a flower farm, even if it is an informal institution, even if it's a factory, is there a way that the human resource in those particular facilities are able to get to give support to the mothers who work in their areas? We also have the Institution for People with Disability and the Disability Council. We're able to sensitize them. We are able to ensure that they get the right information to be able to also give information to their mothers that it is possible. It doesn't mean that if a person or if a mother is disabled, then she cannot be able to breastfeed. Sorry, she cannot be able to breastfeed. All mothers are able to breastfeed if given the right support and care. Also, part of galvanizing is ensuring that there was fire. I think all radio station, TV station, the social media, we had discussions everywhere. And that means we created a fire. I believe everybody was asking, where do we talk? Who can give us a talk on this? Who can give us a talk on breastfeeding? And I think the information have passed. I don't think we are beyond that as much as we are today on 9th, and the week ended on 7th. We are still in action to be able to continue with the work that is ahead of us. So I'll narrow down to what the BFHI components are to make our hospital baby friendly. I'm looking at this because we are at KNH and we endeavor to ensure that we follow the 10th step to ensuring that our hospital is baby friendly, which I'm sure is what the hospitals within the country that have breastfeeding areas are able to follow. So the key, we have 10 steps to successful breastfeeding. And it starts with 2 that are for management, and that is management procedures. We have step 1A, which says you comply fully with the International Code of Marketing of Breast Milk Substitute and the relevant World Assembly resolution. KNH looks very critically in enforcing this rule. We only give our breast milk substitute to those babies who require, the ones that we write as a prescription. We try to uphold that particular step 1A. Step 1B, have a written infant feeding policy that is routinely communicated to staff and parents. KNH, you have made sure that we have the infant feeding policy within all areas that mothers are taken care of. That means the lactation, the labor ward, the antenatal and postnatal areas, and the pediatric wards. We also have in nursery. We also have in any other area that caters for babies, the outpatient. We have those, the written policy in place. We are ongoing ensuring that we have feeding policy within the KNH feeding policy is underway, being prepared. Because remember, we are supposed to summarize or have one that is inherent for the hospital, learning from the one that is national. So KNH is in the process of preparing one for the hospital. Step 1C, establish ongoing monitoring and data management system. KNH has been able to put its data management system online, and we can be able to retrieve data for most of our activities from our online registers and tools. And we are able to trace, you can be able to trace which formula if at all a breast milk substitute was issued, who was it issued to? We're able to see our mothers, were they viewed directly from the time they came in? Was that mother monitored from day one? Nutrition assessment, was it done immediately the mother came? We're able to have that data from our record, and we can be able to analyze that data. So in step 2, it talks about ensuring that staff have sufficient knowledge, competence, and skills to support breastfeeding. KNH is on the way because from way back many years, we have had 2 trainings for maternal, infant, and young child nutrition, and it never stopped. As other places stopped giving that training, KNH has sustained the training for all their health workers to be able to ensure that they have sufficient knowledge, competence, and skill. There is follow-up because remember we have staff changes every now and then. If a staff is changed from one area and comes to the maternity areas where they're dealing with the mother and child, they are able to get the information. Remember also we have staff who do not work in the areas that have mothers and children. They are staff. It could be management. It could be the security person. It could be any other person who requires to know. We have ensured that we have our staff being educated on breastfeeding, the maternal, infant, and young child nutrition. We have a slot every year, 2 slots every year. Previously, we had done the baby-friendly hospital initiative training. Somewhere we did a stop for some 5 years. This year, we are getting back on track, ensuring that we get on track and start the BFHI trainings within our facility to ensure that our hospital is accredited as baby-friendly once the rollout has started, because I know within the country, the rollout has started. So KNH is also on course to ensure that we have those running. We move to the key clinical procedures or practices. Step 3, discuss the importance and management of breastfeeding with pregnant women and their families. This happens at KNH, where we have the mothers being given this information at the antenatal clinic. For those who are aware of KNH, that is Clinic 18, where we have our antenatal mothers coming to get this discussion. And every mother who comes within for care, we are able to give them nutrition information from the nursing side and from the nutrition side, the information is passed about the importance and management of breastfeeding. And step 4, facilitate immediate and uninterrupted skin-to-skin contact and support mothers to initiate breastfeeding as soon as possible after birth. We are on course in ensuring that that act is happening within our labor ward, and we are keen to ensure that it happens. So we are on course. Step 5, support mothers to initiate and maintain breastfeeding and manage common breastfeeding difficulties. This one happens in our postnatal wards. It starts at labor ward and goes all the way to the postnatal wards, where every mother who delivers has to get the information about how to maintain breastfeeding and how to manage the difficulties if they have any, and they're supported to breastfeed their mothers. No mother goes without a nutrition counseling from them and also from the nursing staff. If a nurse realizes that there's an issue, they will always handle it. And no mother is allowed to the postnatal wards not having initiated breastfeeding from labor ward. So we are trying to ensure that continues. Step number 6, do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. This is where I said, yes, we have the breast milk substitute within our facility, but we have followed the right procedure to ensure that they are here as indicated in the Act 2012, the BMS Act 2012, and we only give the breast milk substitutes to those babies who have medical indication. Remember, we receive most of the medical conditions that allow us to be able to use the breast milk substitute. But if it is possible at any one time, we rarely use the breast milk substitute as much as it's available within the hospital. We have step 7, where we it says enable mothers and their infants to remain together and to practice rooming in 24 hours per day. KNH is able to allow their mothers and their babies to stay together 24 hours a day. And I believe for most other hospitals, that is what happens. so that we're able to achieve step number 7. Step number 8, support mothers to recognize and respond to their infants' cues for feeding. This is a skill that is taught at the antenatal clinic, and it follows all the way to the postnatal clinic. Remember, it also happens during delivery, where the mother, during the early initiation, the mother is taught how to put the baby on their chest, and the baby is able to find the breast, and the mother is able to see the hunger cues or the readiness of the baby to be able to breastfeed. So this, we support our mothers to recognize that as KNH. Step number 9, counsel mothers on the risk of bottles, teats, and pacifiers. We are on course in ensuring that we give that information to our mothers once they come during their counseling session. We are able to pass that information, and we're always on the lookout for those who hide in their bags, because some of them hide, you don't see, but you'll be able to follow up and see if a mother has any of those. Because within the facility, some mothers will come with a pacifier, you'll see a teat, but we cancel them. From the time the day one they come for antenatal care, we give them that information. Step 10, coordinate discharge so that parents and their infants have timely access to ongoing support and care. KNH is able to coordinate discharge. We do not have a community unit attached to us, but we give at least a response where they can come back to us for one visit. And if they are going back to the areas where they come from, or the community units where they come from, we're able to give the referral letters or the discharge letters that shows they should be able to access care when they leave hospital at this particular time, the regulated time, at 2 weeks for the mother from cesarean section, the ones for 6-week care, and then follow up at the MCHC clinic. So we are able to coordinate discharge and follow up our babies all the way to 2 years and beyond. So we are on course. Wanted to show that placard. KNH was designated as baby friendly initially in the first surge for baby friendly in 1992 March. And that placard sits at our CEO's waiting room. So any visitor coming to KNH and waiting to see the management, they're able to visualize our baby friendly placard. We are hoping very soonest we'll be able to get the next one, as we are accredited by ensuring that we achieve 80% and above in being baby friendly. So that is one way of ensuring that we close the gap within KNH. The other way we ensure that we are closing the gap within KNH is that we ensure that KNH workplace breastfeeding support room was in place. It has been in place for a while, but we ensured that now it was officially opened by our HR, the Director Human Resource, Mrs. Winnie Mwangi, on 6th August during the launch of our World Breastfeeding Week. She was able to officiate that room, and this ensured that our staff, all our staff within KNH, will be able to access that room if at all they are breastfeeding, to be able to express their milk. It is well established. It has all the supposed items in there as per the Act of Workplace Support. It means that we'll be able to support our mothers, and we'll be able to bridge the gap within our communities. For the mothers, they have areas that they can also be able to breastfeed their baby if they are within the KNH hospital. So thank you. And together we can support breastfeeding for all and close the gap in breastfeeding inequalities. Thank you.
Thank you so much, Virginia, for such a brilliant elaboration on breastfeeding. For now, I welcome the team on the next step as we check on the questions. Agree, you can. Okay, then from anonymous attendee, I ask this: we need to have more discussion on how to support exclusive breastfeeding for working mothers who have gone back to full-time working after 3 months maternity leave. That is, I agree. Brian Mosoti, for exclusive breastfeeding, is it the first 6 completed months or once an infant attains the 6th month? Please clarify because Kenyan guidelines differ with WHO. Grace, you can clear the air on that.
Thank you so much, Robert. So I'll start with anonymous working mothers that we need to have more discussions on how to support exclusive breastfeeding. And it is true, anonymous, that we need more discussion on this, given that most working mothers in Kenya do not receive sufficient support to continue breastfeeding. And they also have challenges which include inadequate maternity leave. Some mothers are not able to access the 90 days as we have already been told in the policies. So there is need to discuss around that. There is also absence of breastfeeding facilities at workplaces or limited employer awareness. So in line with the one of the policies, that is the Health Act 2017, Section 71 and 72, which states that all employers shall provide lactation stations with adequate equipment or facilities. It's important to discuss this so that we can be able to support the mothers to be able to successfully breastfeed up to 6 months. And even though they may be away from their babies, they can be able to express breast milk and even go back with it in the evening so that they can give it to the babies. There's also need to talk about flexi hours, which is also in the Health Act 2017, so that the employers can provide flexi time for their female breastfeeding employees, and so that they can be able to successfully lactate. So going to the other one, or the other question on
Brian,
Brian Mosoti asked for exclusive breastfeeding. Is it the first 6 completed months or once an infant attains the 6th month? Brian, it's important to note that it is supposed to be the first 6 completed months, or alternatively, you can always count up to 180 days from the birth of the baby. Thank you.
Thank you so much, Grace, for that elaborate anonymous attendee known as Muruti Mbogo is giving thanks to Virginia.
Thank you.
Say thanks, Virginia, for the great and timely webinar. What's stopping the nutrition fraternity from lobbying for, number 1, 6 months maternity leave law and banning breastfeeding bottles in Kenya, just as was done with plastic bags? Maybe I can read a number of them so that we will respond. How to receive Biteziki says that how to receive the slides for the presentation. Anonymous attendee, do we have breastfeeding in workplace bill or policy? What's the enforcement for Breast Milk Act in case anyone violates? It's usually stored in shelves in chemists, supermarket, in shelves that are open and could entice breastfeeding mothers. Is that violation true? Virginia, someone has directed a question to you about lobbying, nutrition fraternity lobbying for number 1, 6 months maternity leave and also banning bottles for just like plastic bags. What's your take on that?
Perhaps I can come in on that, so that because if you look at now, whenever it comes to issues to do with the law, you understand there has to be public participation, and also even by the time it's reaching the public participation, there has to be awareness in terms of what are the benefits of us. If you're told you have to give mothers a 6-month maternity leave, how is it going to be beneficial? Because you see, it has to start from the benefits bit in terms of how do we start to benefit both as a government, both as a community, both as the mother who is breastfeeding, both as a family, as a society. So that now if you're able to articulate those issues in terms of what benefits it stands to help us in, you see now it becomes a bit easier now to lobby for it to be a law. But as long as there's that gap in terms of we are not able to picture ourselves, how is it going to be beneficial? If I told you to give the 6-month maternity leave, is it actually going to be beneficial? How does it stand to help us? So we have to first start in terms of how is it helping us? Number two, then now if we have now research showing us in terms of these are the benefits which have been documented over time, this is what is there. You see, now it becomes a bit easy now to lobby for it to be increased to 6 months. But without data, it becomes very difficult, even for someone to enact that law, because you have to look at now what are the benefits vis-a-vis, is it helping us to save in terms of expenditure when it comes to health? Number two, is it helping us to reduce the maternal and infant mortality as an indicator for the health? Is it helping improve the nutrition status of our children and of our mothers, and in general of the society at large? So you see, until we have that documented and in place, we'd like just to appreciate in terms of, in as much as we'd want it to be increased to 6 months, as some other jurisdictions have, it would be prudent for us also to appreciate that at least we have something that we can work with. But moving forward, that's what we need to be advocating for. And for us to be able to advocate for that, we need data to be able to support our suggestions in terms of that we need to increase the maternity leave to 6 months. Because as you can see, even for paternity, there are those who are like, we need to increase the paternity from the 2 weeks to a month. But then now someone else is going to ask, why would you want to increase the paternity to a month as opposed from the 2 weeks? Some are going to say, oh, the father is going to be now watching football rather than assisting the mother in the house. So you see all those things. So we have to have data to clearly articulate in terms of what are the benefits before even we go and enact the laws. Thank you.
Thank you, Andre.
So the other question was about banning breastfeeding bottles in Kenya, just as it was done in plastic bags. Because as you'd even realize, even with the plastic bags, I think this is now an assumption I'm making. The problem perhaps is in terms of the enforcement. Because even you, when you go to your residence, I believe you'll still see the plastic bags being wrapping. For the mama mboga is perhaps using those ones to wrap the mbogas. So we have the laws, yes, but now the problem now becomes in how do we enforce those laws? And the other aspect is in terms of public awareness. Why is it that we are saying we need to ban the breastfeeding bottles in Kenya? You see, if they don't understand why we need to ban the breastfeeding bottles in Kenya, then you see even they won't see the need. Why do we need to ban them in the first place? But once they already see what are the benefits, as we had already articulated in terms of if you can be able to give someone a scenario which they can relate with, it becomes easy for them to look at them in a different perspective. It's more or less like me telling you don't go eat lunch today. You see, there's no justification. Why should I not go eat lunch? But if I was to give you a concrete evidence in terms of, oh, I know how it was prepared or the environment it was prepared in, it poses a health risk for you. You see, at least you'll have a good reason enough. Why should I go take lunch from that particular area? So I think it calls for us, for all of us who are here present, to to sort of like sensitize the public in terms of why do we say we need to ban the plastic? We need to ban the breastfeeding bottles. So that now, if they can be able to see now the benefits of that, then it becomes easy for the laws even to be enacted. You don't even need anyone to enforce. You just self-enforce it by yourself. Thank you.
Thank you, agree. Lydia Mayaka says, how can we help these matters admitted in general wards, especially those with past abdomen, following CS and not ambulant, to practice exclusive breastfeeding, considering infection prevention to the newborn? Alphonse?
Okay, I'll take up that one. So Lydia, for this mother who may have a complication and have a burst abdomen, it's important to note that this mother can still exclusively breastfeed. So long as the wound has been dressed and covered, this mother can be able to attach the baby on the breast and breastfeed successfully. We can also have the healthcare workers assisting the mother to express breast milk, which can be fed to the baby using a cup. So it shouldn't be a problem. And I don't think there is any way that the baby will get infected. Thank you.
From anonymous attendee, says, is it in order to encourage mothers during ANC to massage the breast to increase milk production after delivery? Rosie?
Okay, thank you, anonymous attendee, for that question. That is it in order to encourage a mother during ANC to massage her breast to increase breast milk production. That is not recommended because it can easily induce labor. So we don't encourage mothers to massage breast during the ANC. But in some situations, maybe if a mother has a problem with maybe the breast complications, that can be handled at the ANC by the nutritionist. Thank you.
Thank you, Rosabella, for articulating that. Anonymous attendee also asked, how can a working mom store breast milk in a workplace without fridge from 8 a.m. to 6 p.m.? Alphonse, take up on that.
Okay, thank you for that question. For storage of breast milk without a refrigerator, it can only last for up to 8 hours in a temperate climate like in Nairobi. So if you're working from 8 to 6, those are how many hours? Those are 8 hours. But then you need time to take the milk to the baby at home. So that means the hours will go beyond 8, and the milk will not be will go bad. So you may not be able to use the milk after 8 hours because you run the risk of giving the baby milk that is already going bad, and you may have the baby getting health problems. So if your working hours are up to 8 hours, then the only alternative is to have the baby come, and then you breastfeed, or you can use a cup to give the milk that you had already expressed. But if you are going home past 6, then it will not be possible. Thank you.
Maybe I can also just add to what Alphonse has said, that for moms who are expressing breast milk at their workplaces, we also encourage them to have cooler boxes. You can have a cooler bag, which you can carry to your workplace. And when you express your breast milk, you can store it in that cooler bag, then go back with it in the evening for the baby to use. Thank you.
Thank you so much. From anonymous attendee, at what stage do we give boiled eggs and other stews? I presume that is complementary feeding. That's after 6 months.
So it's safe for the HIV exposed babies to exclusively breastfeed for the first 6 months. And we start complementary feeding as from after 180 days, that is at 6 months, and the mothers are still recommended to continue breastfeeding. And one of the main information that one needs to take in place is that if a mother is positive, the baby is supposed to be put on both, the mother is supposed to be on ARVs. At the same time, the baby is supposed to be put on ART, so that both the baby is protected from getting the virus. So it is very, very crucial that a mother gets the information, because the right information during the ANC and even during the delivery, that's the time they continue getting that information and support that they are supposed to continue breastfeeding exclusively. And both the mother and the child are safe taking medication, and the baby is safe when the mother is giving the right the treatment at the right time. So the babies who are exposed are safe to breastfeed exclusively for the first 6 months. And at 6 months, they start complementary feeding as they continue taking the medication, and they continue to breastfeed up to 2 years. That is the guideline recommendation that is required for those babies who are HIV, who are exposed. Thank you.
Thank you, Josie, for that response. Felista Kiengo, what about in the coastal regions where the temperatures are high? How many hours can the breast milk be stored at room temperature? Agree and check. Felista Kiengo asks, what about the coastal regions where the temperatures are high? How many hours can the breast milk be stored at room temperature?
Okay, Felista from Mombasa. In temperature, I mean, in coastal region where temperatures are much higher than Nairobi, breast milk can be stored for between 4 to 6 hours in hot climates like Mombasa.
Thank you so much.
Well, there is Anangwe. Is asking, or she is asking, sorry, Anangwe Josephine, where is the place of human breast milk banking in support to breastfeeding, like the one in Pumwani? Well, I think for that one, you'll realize it came to be as a result of they wanted to see if in terms of is it feasible. They had to do first the feasibility of it first. Are people accepting to actually even be able to donate the breast milk itself? Because you see, you can't put it in a larger scale until you're able to look at now the feasibility of it, because you might end up putting it on a larger scale, but then now there's no one to embrace that aspect of donating human breast milk. So so Pumwani was more or less being done as a feasibility study to see if at all, is it going to be acceptable with people? Are they going to be willing enough to come in and be able to donate breast milk for that particular purpose? So that's why you can see it is not really on a larger scale. It's more or less a study kind of, so that now you're able to look at the feasibility of it and the sustainability of it also.
Thank you, Agri, for that response. Madam Edna Warento, thank you very much, Virginia, for the comprehensive presentation and being very eloquent. My question is it possible for the breastfeeding mothers to be allowed to leave early so that she can take the expressed breast milk to her baby in good time before the milk expires? There should be an arrangement with administration. Is this possible? Thank you. I think it's possible, upon arrangement by the administration. We have various, rules and regulations, and, they can, perform that, and, we are saying that, at workplaces, the employee support,
I can support on that, on time given to the employees to leave early. So the institutions requested that they can allow breastfeeding employees to work at the day shifts instead of night shifts to support their continued breastfeeding at night. Breastfeeds increases the milk production. And on that note, where we are, Mrs. Warento has asked about the releasing of staff in good time for them to take the breast milk home earlier. That is the request that is being made, and of course with the act, I believe with the institutions, that arrangement can be done. And here in KNH, that is actually the practice where a number of our colleagues, the staff who are on that lactating period, they are allowed to come a bit late and also leave a bit early. And that is the request that some of these institutions also can also do the same, so that we can continue having the support for our mothers at this particular time of breastfeeding. In KNH, that is the practice, and we thank the institution for the support.
Before we end that, we can check on, two questions, from Helen Anyango. How can we support mothers who has had a mastectomy of one breast and has delivered twins? Grace, you can.
Thank you, Helen. So for this mother who has had mastectomy and has delivered twins, it's important to note that we can still successfully breastfeed from one breast. So for this mother, we shall support the mother to be able to continue breastfeeding and at the same time expressing breast milk. So this is a mother who you'll guide to start expressing as early as possible, because you realize that within the first 1 to 3 weeks, the baby is consuming very little milk. And that is the time, again, we find that mothers have plenty of milk. So we encourage them to express and store that milk so that it can be used when sometimes the milk flow goes down. But otherwise, the mother can still successfully breastfeed with support from the healthcare workers. Thank you.
Thank you, Grace, for the response.
Another thing I wanted to, there's a question that came in that is none recommended while breastfeeding. No, it is not recommended. In fact, none is a part of the designated products, and therefore we do not recommend anything else apart from breast milk during the first 6 months. And that is why we talk about exclusive breastfeeding. And the meaning of exclusive breastfeeding is giving breast milk only to the newborns, not even water should you give to that newborn until they attain the age of 6 months. Thank you.
Maybe, Virginia, you can add something.
I saw one question about how does the mother increase breast milk? The breast milk has reduced. One of the major difficulties for breastfeeding mothers is they don't have enough milk, or it has reduced. So how do you ensure that milk production is increased? The more you breastfeed, the more milk is produced. It's a hormone reaction. If you do not breastfeed, the breast does not produce milk. So we have to ensure that you breastfeed as often as is possible, not longer than 3 hours in between the feeds. It can be 2 hours. It can be the next not longer than 3 hours. If you do not breastfeed, the breast will dry up. So you have to breastfeed, and if you have to go to work, ensure that you empty the breast every 2 to 3 hours so that we have that sustained milk production, and then we are able to breastfeed our children well up to 6 months. Even if the baby is 4 months, we have to ensure that we keep up the milk supply by making sure that we breastfeed our babies or we express timely. And that is the workplace support, where wherever you go, you need to be able to have a place to express milk and be able to store until time to get home.
Thank you. Bruce Kulundu asked, how can we help the small teenagers and not breastfeeding in a correct manner? I think good positioning, attachment to the baby is key. One needs to work with the teenagers, support them, to show them the right position and attachment so that the baby can latch well, and also to prevent other problems like cracked nipples, which are results from poor positioning and attachment.
To add on that, I believe the ANC care is also very, very crucial on that. So it's very, very important to encourage our young teenagers to attend the antenatal clinic during that period of pregnancy, and that is where they'll get proper support and will attain a good breastfeeding or rather lactation period when they get the right information when they attend the antenatal care. Thank you.
Well, there was an anonymous attendee. Is it possible to incorporate breastfeeding rooms even at workplace? Of course, it's very much possible. It all calls for the goodwill of the employer to be able to support that. Because like here in KNH, we've been having the breastfeeding room since 2019. So as you can see, it is very much possible. It all calls for the benefits is going to accrue. Because if you have to look at that room, you can remember, if you're able to support your employees to be able to breastfeed their children without having so many stresses, you see, you're trying to reduce even in terms of the infection rates in terms of the child. So you're trying to sort of sort issues to do with someone having to be on sick of to go attend to a child simply because they left the child under the care of someone else who was not, or they were giving something different, which predisposes the child to more infections. It increases the number of sick offs the person would need away from work, which also is going to burden the people who are working, the people who are going to be left to work. Because remember, if someone is not at work, then it means someone else has to shoulder that burden of the workload that they were supposed to have covered. So at the end of the day, we have to see a way of how do we negotiate for this such that all employers are able to incorporate breastfeeding rooms in their institutions, wherever they are, because it is quite important for us to incorporate those breastfeeding rooms for us to be able to have a healthier nation. Thank you.
Thank you. Thank you for that. How anonymous attendee asks also, how do you manage cracked nipples caused by inverted nipples?
Yeah, for that. Anonymous attendee, a cracked nipple comes from the baby not having latched properly on the breast. That means the baby is only breastfeeding from the nipple, and that is what is going into the baby's mouth. And once they rub on the nipple, if it is inverted or flat or even a normal nipple, if the baby keeps rubbing on the nipple, it will be cracked, and it will go all the way. Critical whether the breast is inverted. Okay, so it's critical if a nipple is inverted, flat, or any other type of nipple, that the baby is properly attached to the breast. How it starts is we need to have the baby properly positioned. If the position of the baby to breastfeed is wrong, the attachment of the breast in the baby's mouth is actually wrong, and that is what will cause a cracked nipple. So it's very critical we get it right, get the right positioning, get the right attachment, that the baby is breastfeeding or latching on the areola, the black part of the breast, that they are not only breastfeeding from the nipple, because if they keep rubbing it, it gets cracked. So they have to get most of the areola into the baby's mouth, where now the baby can be able to take it, because whether it is inverted or flat or normal, the nipple is only there to pass the milk out, but the baby is supposed to actually latch on the areola and breastfeed or get milk from the areola part or the black part of the breasts. So all they need to do is get a proper position and also get the baby to latch properly on the breast, and the nipple will be fine.
Thank you. Again from anonymous attendee, my friend started giving the child a mixture of water and glucose because she started giving feed since she's going back to work. The baby is 4 months. What's your thought on that? Alphonse?
Okay, that is not what we are advocating for. We are advocating for the baby to breastfeed exclusively for the first 6 months of life without being given anything else apart from breast milk. So if you know you are going back to work, say after 3 months or 4, you need to start expressing breast milk early enough, and you store the milk for your baby so that by the time you are going back to work at after 4 months, you have stored enough milk for your baby, and the baby will be able to use that milk while you are away at work. So it is that practice is not good and should be discouraged.
Well, if I can add on to that, remember the main reason why you're asking pregnant mothers to attend the ANC is so that you can be able to recognize some of these things quite early in terms of being able to support them, being able to prepare them for breastfeeding. Because if they don't attend the ANC, you see now there'll be such scenarios whereby you're going back to work, but you don't know what to give the child. Because perhaps I can just sort of like make an assumption from this, perhaps would be the mother here might have missed several ANC clinics whereby she missed on this critical information that needed to be delivered to her in terms of how do you prepare, how best do you prepare for breastfeeding your baby exclusively. You see, it's not really it's more or less a process that you need to be prepared about rather than an event. It's not an event whereby it just happened. No, you have to be well prepared in terms of, oh, I'm going to work. How will I be able to successfully ensure that my baby is exclusively breastfed? So then now you'll be able to sit down with the person attending to you at the clinic and be able to advise you in terms of these are the options that you have in terms of you preparing for breastfeeding your baby exclusively, and you'll be able to be taken through and be able to avoid most of these scenarios that you're having in terms of giving the child water and glucose. Because as you can see, remember the child needs protein. He's only getting glucose out of it. So this child is likely, most likely, going to become malnourished at the end of the day because he's not going to be getting adequate nutrients that he or she needs at the end of the day. Because remember, the child also needs a bit of fat, which is in the breast milk. As in this particular scenario, he's only getting glucose. So remember, and fat is quite essential even in terms of growth and cell proliferation. So it's quite important for us to be able to encourage them in terms of, in as much as you can see a mother is pregnant, encourage them to attend the ANC clinics so that now such issues can be able to be addressed way, way early, even before they give birth, so that now they are well mentally prepared and psychologically prepared to handle it once they have the baby. Thank you.
Thank you so much for your contribution. Thank you for all panelists, presenter, and all those who attended today's webinars. We thank you for those who asked the questions. We also thank you for such a question because it informs, through such discussion, it informs and it brings more knowledge. So thank you so much. Let's see you in the next webinar. Bye.